I'm sorry I cannot be today in the meeting, but I can speak after some surgery I had in my knee, and I'm sure that you people will understand. So let me begin by saying that my topic is cardiovascular polypill for secondary prevention, a call to action 2007-2022. Let me go step by step in the slide that I am presenting here. First, we all know that myocardial infarction and stroke are the #1 killer today. But one of the main reasons that we have recurrence of events is because poor adherence to medications. Just let me give you an example of contemporary studies, the Syntax study, our Freedom study, and the BEST study. When you look at the medications that these patients with coronary artery disease should be taken, actually the 55% were taking the medications, 45% were not, and some differences in the 3 studies. Actually, these figures are reasonably better than other figures in the literature. I would say that over 50% of patients with coronary artery disease, they are not taking all the medications that the guidelines suppose they should be taken. And then there is a question of access to medications, depending on the economy of the community or of the country that we are talking about. This is from the Pure Investigators study. And here on the left is coronary heart disease. You see no drugs, 1 drug, 2 drugs, 3 or more drugs. Well, in a high-income country, we're reasonable. 50% of the people take 3 or more drugs as they are required for coronary artery disease, not different than what we said before. But look at here, low-income countries. In fact, 75% are not taking any drug at all. It's even no 1 drug. And the same happens with the stroke. So we have a problem of adherence in coronary artery disease and a stroke, and things are much worse when in countries that are low-income countries. Well, and this leads now to the issue of the poor outcomes, and that is this adherence or poor adherence and difficulties in access, they have repercussions in outcomes. Absolutely. This is the study that we did with the insurance company Aetna, with 14,000 people who took actually myocardial infarction, and we were able to tabulate the adherence to the medications as we check on the pharmacies in terms of prescriptions and cardiovascular events. And as you can see, when the total number of medications in a way was less than 40% in terms of compliance, this was a significant cumulative incidence of events. And only when the compliance was more than 80% of the time that you are supposed to take the medications, the cumulative incidence of events was actually significantly lower. So a relationship between adherence and cardiovascular events. And now comes the issue of costs. What happens if we don't take the medications that we are supposed to take after coronary artery disease and after a stroke? Well, to make the long story short, the cost of low adherence in the United States could be up to $300 billion each year because of hospitalizations, recurrence of events, and so forth. So it's a very expensive enterprise, in addition with an increase in cardiovascular events because of the lack of adherence. Well, with all of this, was in 2007 that we began to think about a polypill for patients with myocardial infarction and stroke. And we started with myocardial infarction. And this is how the story started. It was 2007 where we already had a significant kind of a feeling as we were entering the Freedom trial that the adherence to medications was actually low. And we decided to consider the development of a polypill. Well, I will tell you the story of the polypill. Basically, I went to the pharmaceutical companies in the United States. I don't mention the names. And all they said is, this approach simplistic approach of a single pill is absolutely attractive. And that is very interesting. But you know what? We are not interested. And let me tell you why. Because the question of putting pills together was actually, there was great experience at that time with HIV. And these companies developed polypills that were very effective, but highly costly to the companies. So here we are, starting with a polypill, but nobody interested to start with. I went to Spain and I found a company, Ferrer company, pharmaceutical company, with the CEO was actually very socially oriented. And she said, you know, this not only can help poor countries, but actually the polypill would be much cheaper than taking all the pills that patients with myocardial infarction have to take. And all of these concepts that a polypill can improve adherence, can prevent cardiovascular events, favor global accessibility, all of this was in our minds, and we took over and said, let's develop the polypill between the National Center of Cardiovascular Investigation in Madrid, like NHLBI in the United States, and Ferrer Laboratories. Well, and the question is, how do we start? Well, we like to start, but we had a problem. We had to develop actually about 50 polypills before we had one containing aspirin and actually ACE inhibitor, simvastatin, and then the other one was ramipril, 50 to show that the three pills together did not interfere pharmacologically with each other. And this is what we learned. When you take the pills separately, they might not interfere with each other, but when they are together, they do. And these actually 50 polypills that we developed, the cost was close to 25 million euros. So we said, this is really a problem. And the company and myself met and said, well, we have now some support for a project. Let's try. And this is actually what I'm presenting to you now, the FOCUS study. The FOCUS study was a polypill, the first one that we developed, again, with simvastatin, ramipril, and aspirin, that in a number of countries that I will present in a moment, we look at whether patients with myocardial infarction, over 2,000 patients, where half of them treated with the polypill have better adherence to such polypill than those who were taking the separate pills, aspirin, the ACE inhibitor, and the statin separately. And this is actually what we found. First, the countries that enter into the study: Brazil, Argentina, and Paraguay, Spain, and Italy. And just pulling all the data together, we found that the adherence to the medication in the group that they took the medicines separately was 45%. And actually, those who took the polypill was much better. So the polypill, no question, increased adherence. And this is actually the FOCUS study. The company manufacturing the polypill was very worried, however, because of the high cost that the polypill had. But anyway, we all encourage ourselves thinking that this could really be very good in the future in terms of using a single pill and improving the adherence, cardiovascular events decreasing, and lower cost. Well, this is now comes into clinical outcomes. We have a polypill. Actually, we had two polypills. One had simvastatin, the first one, and this other one had atorvastatin. And the question is, what about clinical outcomes? And now I have to go again to the retrospective study that we worked with Aetna, the insurance company I presented before. And that is, we certainly prove, as I already showed, that better adherence was decreased in cardiovascular events. But this was a retrospective approach. We needed to have a prospective study with a polypill versus the pills taken separately in patients with myocardial infarction. And this actually, we were very lucky that we were funded by the European community, the Horizon 220, to do the study. So we all were very, very frustrated by the cost of the polypill, but still we kept going, getting the appropriate grants to test this process. And now we are about, actually, I will be presenting the results today, which is 15 years after 2007, when we actually started this whole program. So whether this is resilience, whether this is passion, whether this is belief into this is going to work, call it whatever it is, but we persisted year after year until 2022, when we got the results of the SECURE trial. Now, Dr. Sharma asked me to present the other trials. There is no other trial of secondary prevention. There are studies on primary prevention, difficult to know what pills to be used in people that we don't have guidelines of what to use. So here we have guidelines for secondary prevention, what to use in patients with myocardial infarction. And this is the SECURE trial that we presented about 3-4 weeks ago in the European meeting and was just published in the New England Journal of Medicine. This is the study, the prospective SECURE study. Near 2,500 patients were recruited in 113 centers across 7 European countries: Italy, Germany, France, Poland, Hungary, the Czech Republic, and Spain. And Stuart Pocock, as you know, great statistician from the United Kingdom, helped us in the design of the study. And this is where we have actually 2,500 patients post-myocardial infarction over age of 65 years. This is the Polypill on the left, 100 milligrams of aspirin, atorvastatin 20/40, and ramipril 2.5510. Let me explain to you. People who didn't tolerate 40 milligrams of atorvastatin, we used 20. In ramipril, the first 10 days we started to 2.5 milligrams, then 5 milligrams, and then 10 milligrams. Why? To avoid the reactions, the allergic reactions, even anaphylaxis when you use ramipril, and you have to start with a very low dose. Most of our patients with the Polypill use 100 milligrams of aspirin, atorvastatin 40, and ramipril 10. And these are the pills taken separately. Well, the median follow-up was 3 years, and the primary composite endpoint was cardiovascular death, myocardial infarction, stroke, or urgent revascularization. The key secondary endpoint was cardiovascular death, myocardial infarction, or stroke, so no urgent revascularization as part of one of the variables. Actually, I am not going to go into the study flow chart, but I have to make a comment. In 14% of the patients, COVID prevented a good follow-up. And in this 14%, what we did is we have the follow-up until the last visit. And that's basically maybe a limitation of the study, but was the only way to overcome the issue of COVID and the study to keep progressing. Now, just to give you a sense, the average age in both groups was about 75 years, females 31% in both groups, and Caucasians 99% in both groups. So actually, most of any parameter we look at were very similar between the group treated with Polypill and the group treated just conventionally with the pills given separately. Now, it's fascinating and perhaps also frustrating to look at the risk factor profile, very similar in both groups. But can you imagine former or current smoker following actually the cardiovascular event 15%, 13% in the usual care group. Diabetes, you can see 42%, hypertension 77%. So a high risk factor profile in this population with myocardial infarction. And these were the results, very rewarding. This is the primary outcome, composite of cardiovascular death, myocardial infarction, stroke, and urgent revascularization. Here is the Polypill in the bottom. Here is the usual care, taking the pill separately on the top. And this is the primary outcome. 2 points I'd like to make. The first is the curves begin to separate always from the very beginning. Very interesting. And then continue to be separated at 4 years of follow-up and separating more. Maybe if the study had continued, the results would have been even more striking. This is the primary outcome. And the secondary outcome, equal or even more significant, composite of cardiovascular death, myocardial infarction, and a stroke. And also with the two characteristics I mentioned, the curves separating very early and continue to separate at 4 years of follow-up. Now let's look at the data directly. And here you have the primary outcome. In green is the Polypill, in red are the pills taken separately or usual care. Events of primary outcome, 9.5% in one group versus 12.7% in the second group. When you go into the secondary outcomes composite of cardiovascular death, type 1 myocardial infarction or ischemic stroke, 8.2%, 11.7%. And interestingly, cardiovascular death by itself was very significant, 3.9%, 5.8%, actually a 33% relative percent reduction of cardiovascular events. And so ischemic stroke. So this was, excuse me, the 3.9% is cardiovascular death, type 1 myocardial infarction was the second, 3.6 versus 5%. So very significant results. And the question is this by chance? It cannot be by chance, because we have here all the subgroups, pre-specified subgroups that we had from the beginning of the study. And in all of them, there was all having a trend of favorable results with the Polypill. The statisticians know this, and certainly Dr. Stuart Pocock was very strong. This is not by chance. This is a reality when you have all the specified subgroups all going into the same direction. And here we have adverse events, just specific adverse events, bark bleeding, refractory cough, renal, drug allergy, all the same between both groups. There was no difference. The question is how this works. Why the Polypill provided such important or interesting results? Well, first we look at adherence. And we use the Morisky adherence scale, which is actually you surveil the patients with a number of questions. And depending on how the questions are, less than 6 points means low adherence, 6 to 7 points medium adherence, and high level of adherence was about 8 points. And here you look at the tables, for example, at 6 months and at 24 months. At 6 months, a high adherence was 70% in the Polypill, 62% in the usual care. Low adherence, 5.5 in the Polypill, 9.5 in the usual care. When you look at both aspects, the results were very significant in favor of the adherence of the Polypill. And here's at 24 months, 74% high adherence to the Polypill, 63% high adherence in the usual care. And here the results of low adherence, 4.2, 6.9, the results very significant. So this data in itself points out that adherence certainly is important in terms of explaining part of the results that we presented. We had a surprise, not really, because we found the same in the focus study. You don't know, you cannot quantify how aspirin prevents clots. Even Ramipril at the dose we gave, you cannot quantify blood pressure, but you can quantify statins. And the LDL cholesterol was the same in both groups. So here are three possibilities. One is the possibility that in fact the LDL cholesterol was equal because the drug that we gave, the statins, actually they have effects not on the LDL cholesterol, but anti-inflammatory drug and anti-thrombotic drugs, as have been shown in some studies following myocardial infarction. This is actually in the literature. And maybe the LDL cholesterol is affected later. Possibility number one. Possibility number two, most of the patients that took the three drugs separately the atorvastatin dose was 80 milligrams, where our dose in the Polypill was 40 milligrams, according to the suggestion and advice by EMA and by the advice of the FDA. That's what it is. And the third possibility is that actually statins don't work. Without it, we believe on the first two that we mentioned, the possibility of anti-inflammatory and antithrombotic effects. But this is basically what we found, exactly the same as we found in the FOCUS study. So here are our conclusions. And the conclusions are a treatment strategy based on a polypill containing aspirin, atorvastatin, and ramipril led to fewer recurrent cardiovascular events following myocardial infarction, presumably due to improved adherence. Use of a polypill strategy is safe, with no differences in adverse events between groups. And perhaps the most interesting one is the third one, and the use of a cardiovascular polypill as a substitution approach could be an integral part of a global strategy to improve secondary prevention. And the last question, in green, overall cost, we already have the data, and this is going to be published very soon. Two pieces of information showing that the polypill is significantly less costly than the pills taken separately in patients with myocardial infarction. And here is a statement made by the group at the WHO in 2003 that is very interesting in the context of the study that we just presented. Increasing the effectiveness of adherence, interventions may have a far greater impact on the health of the population than any improvement in a specific medical treatments. I think this statement is correct. I would say that today, maybe we do lots of trials, lots of studies, technologically perfect, interventions versus no intervention, one intervention versus the other. But are we keeping track of adherence? And I have to tell you my emotional status in the FREEDOM trial. As you know, the FREEDOM trial were patients with multivessel disease and diabetes. And certainly the results were very striking, as you recall, is in such patients at high risk, CABG was superior than actually stenting. And in this population of over 2,000 individuals were patients with, again, with multivessel coronary artery disease. About 6 months later, after the results were published, I got into, I would say, a depressive state, because I decided to look at the adherence in the FREEDOM trial, not only to the medications, but also to better control of obesity, the diabetes, hemoglobin A1C, blood pressure, and you know what? Only 25% of the patients in FREEDOM, whether they were treated with CABG or they were treated with stenting, really took the appropriate medications that are supposed to be taken and reaching the endpoints they were supposed to reach. So this study that I'm presenting to you today not only is striking in terms that for the from the beginning nobody believed on, and this is a 15-year step by step with the results that I presented to you before, is striking, is exciting, but really points out to the fact is, are we paying enough attention to the issue of adherence in all the studies that we are involved? And I think this is the first principle that I would like to bring into you today. The second principle is that, you know what, this may change the polypill, the way we treat our patients with coronary artery disease, stroke, and high-risk populations. And actually, if it is more affordable for low economy countries or developing countries, I think is a significant advance. And this leads to the third point. I am asked all the time, what about primary prevention? And my answer is, I don't know. I just focus on secondary prevention because we have rules and regulations that tell us what patients should be taken. With primary prevention, I say maybe there is a future there. The problem or the question is, what drug or polypill are you going to use in primary prevention? we don't know if the patient has high or low blood pressure. Are you going to give aspirin for primary prevention when in fact the guidelines tend to say that only in a very high risk groups of primary prevention aspirin should be given? So I don't want to close the door for primary prevention. I don't want to because we need more information. But certainly the information that we have now in terms of secondary prevention following myocardial infarction, now we are more going to move towards stroke and perhaps in patients with very, very high risk of cardiovascular or coronary vascular disease, in which actually the medications being given here are appropriate. Final question. Doctor, you didn't use beta blockers. Why? Well, I don't know what patients with myocardial infarction really need beta blockers. We actually have a prospective trial at this moment, see who should use beta blockers following myocardial infarction. But this is not the reason of why beta blockers were not used in the Polypill. The reason was very simple. When we put beta blocker in the Polypill, the whole pharmacokinetics of the Polypill fall apart. And this is what I tried to say from the beginning. To develop a Polypill, theoretically speaking, is very easy to talk about. But to have the pharmacological effects of each of the ingredients being the same than when the pills are used separately is a completely different story. A story that the FDA pays a lot of attention in terms of approval of any type of pharmacological agent, particularly when we talk about a Polypill of the kind that we are talking today. This is different than a Polypill for blood pressure. Although the Polypill in blood pressure does, whether it's a diuretic with an ACE inhibitor, is to treat blood pressure. The problem is when we have a heterogeneous disease like coronary artery disease, in which each of the ingredients, whether it's an ACE inhibitor to stabilize the blood vessel, we are not giving this for hypertension. Whether it's aspirin to prevent a blood clot, and whether it's a statin to lower the LDL cholesterol, and perhaps inflammation, as we mentioned before, or even thrombotic phenomena, is a completely different game. So let's be sure, when we talk about a Polypill, here we are talking about a Polypill that gets into many mechanisms of disease, and this is why several pills are being used that are different. Anyway, I finished my presentation. I feel very bad I cannot be with you today and to answer all the questions that you have, but I like to really give my thanks to the organizers of this meeting, and particularly with Dr. Samin Sharma, who always gave me the opportunity to give a talk or to present some new information in this particular seminar. Thank you all.